Welcome to ICU Primary Prepcast.
Hi, I'm Maddie.
Hi, I'm Swapnil, and welcome to yet another snippet. How are you, Maddie, and how's things?
I'm good. I'm trying to think what's new. March, my husband was away for 2 weeks in Europe, so I was solo parenting that time. He had a great trip. I did fine, but I was glad to have him back and
That's
to
that's
have
right. It's now your time to do the same thing, I guess.
yeah, I need to plan a trip.
That's right. So today we are going to dive into the fever and hypothermia. So can you please compare and contrast fever and hyperthermia using the following headings? Physiological mechanisms, causes. Sorry.
Yep. So fever and hypothermia, they're both elevation of the core temperature of the body, but the underlying mechanism is different. So for fever, that's a normal part of the innate immune response. So it's physiological, whereas hypothermia is elevation of the core temperature due to a failure of thermoregulatory responses to manage internal or external heat gain. So with a fever, thalamus is like your body's thermometer or thermostat. The hypothalamus controls what is meant to be a normal core body temperature. So with a fever, that set point is increased and it inappropriately triggers body's heat generation and conservation mechanisms. So you get shivering and vasoconstriction. So the body thinks that this new set point is the normal core temperature for the body. Whereas with hypothermia, the hypothalamic set point remains unaltered, but the body's cooling mechanisms such as vasodilatation and sweating are overwhelmed. And the increased temperature that it results in causes increased oxygen consumption and metabolic rate. So you'll see things like increased heart rate, respiratory rate, and then eventually a cytokine-mediated inflammatory response. So you'll see people with severe hypothermia, they can get multi-organ dysfunction, and then that's also how people can die in these situations. And we've seen it like recently. There's been that heat wave. Speaking of Europe, in Europe, in Paris, where people have actually died because of hypothermia. So, from a cause perspective, from fever, it's often exogenous pyogens. So the things we usually think about is some sort of microbiome, usually things like bacteria. So, for example, if we think about gram-negative sepsis, so the gram-negative bacteria have lipopolysaccharide endotoxins, which can trigger this fever response. Or, for example, gram-positive organisms like Staph aureus have entero or exotoxins. Or things like fungi can also stimulate the T cells and the MHC class 2. So this also basically cause the hypothalamic set point to increase. Non-infectious causes can also result in fever. So this includes things like tissue damage, ischemia, malignancy, autoimmune conditions, and they directly stimulate endogenous pyogens. So all of these then cross the blood-brain barrier to the preoptic area of the hypothalamus. And as we talked about, the hypothalamus is that thermostat for the body. And this induces prostaglandin E2 production and sets the hypothalamic thermostat higher and results then in heat conservation mechanisms, which include things like vasoconstriction, behavioral changes, like going inside, trying to find something warm, or heat generation, such as shivering, or thermogenesis, such as uncoupling proteins in brown fat for kids or for babies, or muscle in adults, which release ATP and heat. And then when this new hypothalamic set point is reached, the hypothalamus maintains it like we normally do in the non-febrile state. From a hypothermia point of view, it's usually the causes can be divided into external heat gain, internal heat gain, or impairment of thermal dissipation. So external heat gain is things like very hot ambient temperature, or if you're exercising a lot in the heat. Internal heat gain is things like increased metabolic activity, so things like pheochromocytomas or thyroid storm, or if you have status epilepticus, or things like malignant hypothermia or neuroleptic malignant syndrome, or drugs such as sympathomimetics or anticholinergics. Or you can have an impairment of thermal dissipation. So this can include things like drugs such as ecstasy and cocaine, TCAs, again, serotonin syndrome or neuroleptic malignant syndrome. And often there's a combination of these different mechanisms and causes that then result in hypothermia.
Thanks, Maddie. So I think the understanding the difference between the fever and hypothermia is really important. Now, moving on to how we manage it, and I think one of the most commonly used drug in intensive care unit is probably, as people know, is paracetamol. So, can you please outline the mechanism of action of paracetamol and list its adverse effects, and also outline the mechanism of toxicity?
So the mechanism of action, it's very interesting for a drug that we use so commonly. The actual mechanism, it hasn't fully been elucidated, but it's thought to mainly be via COX inhibition. And COX is important in converting arachidonic acid to prostaglandins. So there's a lot of different subtypes of COX, such as, and I've heard, like, actually went into a deep dive on this, and there's something called COX-3, but some people think that doesn't exist and it's just a variant of COX-1 in the brain. But anyway, some articles were saying the inhibition of COX-3, which is maybe a variant of COX-1 that just occurs in the brain, is thought to be one of the primary mechanisms of action of paracetamol. So through this inhibition, it reduces prostaglandin E2 production. And as we talked about when we spoke about the physiological mechanism of fever, that prostaglandin E2 production is an important part of the causing the hypothalamic thermostat to be reset to a higher temperature. So this causes the antipyretic effect. Also, the decreased prostaglandins within the CNS reduce pain perception, as prostaglandins can inhibit endogenous pain control mechanisms. So that can result in some of the analgesic effect of paracetamol. Paracetamol is also thought to weakly inhibit COX-2 and COX-1 peripherally, which reduces prostaglandin production and maybe causes a minor decrease in inflammation. But this is only thought to be minor. So compared to something like NSAIDs, it's not thought to have a very significant anti-inflammatory response. Paracetamol is thought to only inhibit prostaglandin synthesis when the surrounding levels of arachidonic acid and peroxides are low. COX-2 is generally the predominant form of COX in these situations. So as these levels are high in the peripheries in inflammatory state, paracetamol has a relatively weak anti-inflammatory or peripheral effect, unlike in the CNS where peroxide levels are quite low. Paracetamol is also thought to work through non-COX mechanisms. So one mechanism is through a serotonergic effect by stimulating descending serotonin pathways, and this blocks the transmission of nociceptive signals from the periphery to the spinal cord, also aiding in the analgesic effect, and also through the endocannabinoid system. So a metabolite of paracetamol is AM404, which prevents reuptake of anandamide. And the increased concentration of anandamide stimulates the cannabinoid receptor type 1, which reduces excitatory neurotransmitters and causes an analgesic response. AM404 also activates a vanilloid receptor called TRPV1, which also results in analgesic effects. In terms of the adverse effects, these are very rare, especially in sort of recommended doses for paracetamol. So we can think about them as like the mild effect, severe effect, long-term use effects, and things about supratherapeutic ingestions. So from a mild effect point of view, the most commonly reported are things like nausea, constipation, headache, dizziness, and rash, but even these are thought to be quite rare. Severe effects are very rare in therapeutic doses, but include things like anaphylaxis, immune response like TENS or Stevens-Johnson syndrome, but again, very rare. There's been some reports of acute tubular necrosis and hemolytic anemia, but the hemolytic anemia is mainly in patients with G6PD deficiency, but again, very rare. And from long-term chronic use of paracetamol, there is a minor increase in GI bleed and a small increase in your baseline blood pressure. But again, this is in only a very small proportion of patients. We know that supratherapeutic ingestions can be life-threatening and could actually be fatal, and they cause acute hepatotoxicity. So this usually starts with non-specific symptoms of nausea, abdominal pain, and vomiting in the first 24 hours. And then the next 24 to 48 to 72 hours, there's signs of acute hepatotoxicity with jaundice, confusion, coma, lactic acidosis, and deranged LFTs. And the mechanism of this toxicity is due to the metabolic pathway of paracetamol. So paracetamol is mainly metabolized into sulfate and glucuronide conjugates, and that accounts for 30% and 55% respectively of paracetamol metabolism. And they're both non-toxic. But a small percentage of paracetamol is metabolized by cytochrome P450 and 2E1 to NAPQI. And this is a toxic metabolite. Normally, in therapeutic doses of paracetamol, this NAPQI is detoxified by glutathione dependent conjugation reaction into things that are non toxic, so non toxic metabolites. But when someone has had an overdose of paracetamol, the phase 2 conjugation enzymes are saturated and a high proportion of paracetamol is converted to NAPQI. And this causes a depletion of glutathione. And if glutathione isn't present to make the NAPQI non-toxic, it accumulates, binds to proteins and enzymes, and causes denaturing of proteins, oxidative stress, mitochondrial dysfunction, and significant hepatocyte necrosis, causing acute liver failure.
Thanks, Mary. So I guess this has been asked in the previous exams multiple times, and I think now more focus is also understanding the candidate's knowledge around how do we measure temperature, what different devices do we use in ICU to measure temperature, and obviously the toxicology will be the how does NAC work in paracetamol toxicity. So I guess sometime probably in the next episode we will cover dive more deeper into the temperature measurements.
Done that before.
Oh, sorry.
Mm.
Did we? Oh.
Yeah, we've done one on temperature, like different ways of measuring temperature. And
oh, sorry, we deleted it. Okay. So I guess, yeah, so I think it's important to understand the temperature measurements, temperature management in ICU, because that's becoming much kind of more favorite topic for examiners. So thanks, Maddie. That's the end of our today's snippet. We'll be back with another snippet in months' time. Till then, goodbye and have a nice time.
Thanks for listening, and see you next time.